Thanks for tuning in today. I'm Dr. Nick, the Incrementalist. Join me as I seek out the small incremental changes being applied in other industries that we can learn from and that can be applied in healthcare. Can these changes bring immediate value, but also add up to the big improvements and revolution we need in healthcare? Come along with me to explore the possibilities. My innovative guests from around the globe have used small incremental improvements to achieve their moonshot.
And today I'm delighted to be joined by Dr. Tom Hale. He is the Chief Medical Officer at VirtuSense. Tom, thanks for joining me today.
Nick, I'm really happy to be here, particularly to talk about some of my favorite topics in healthcare revolving around the technology aspects and how that can improve care.
Absolutely. So for the benefit of the listeners, as I always do, tell everybody a little bit about your background. You're not just a doctor, you're actually a doctor. Share a little bit of how you got there and some of your sort of journey to that point, if you would.
No, I appreciate that. Actually, it's been a very circuitous one, which I guess most of us have. A straight line it has not been. I got a PhD in pharmacology from St. Louis University back in the 70s, and from there went on to medical school, board certified in internal medicine, and started my own private practice. It was during that time that was the onset of managed care. And it came to the realization that if physicians and caregivers didn't band together, that we might not do well, and because we didn't have the information bases that the insurance companies had. So I became president of Mercy Medical Group, which grew from rip-roaring 17 physicians to actually 750, and was that president for 15 years. During that time, I was asked, because I had big interest in technology, actually in electronic medical record, and you'd appreciate this, I actually had a group of physicians sitting in a room with Dragon Speak on a laptop trying to do our notes that way. It was a total disaster at that time, back in the 90s, as you can imagine, as the speed of the computers couldn't keep up. But became the lead physician for our Epic implementation of 44 hospitals and 2,000 physicians. And that's where I really cut my teeth in that technology and software business. It was during that time that I got a master's in medical informatics. And the reason I did that, honestly, was that I didn't know whether my IT people were telling me the truth or not, because I didn't have any kind of basis for it. So I got the master's in medical informatics, and I will tell you afterwards, I still didn't know, but they didn't know I didn't know. So I got a lot more truthful information from them at that point in time. Became the executive medical director for our Center for Innovation, which evolved into virtual care, because that was where all the innovation was happening, and was the clinical architect for the world's first virtual care center, which was erected in St. Louis, where I stayed for another 5 years, where actually my age and my frustration with not-for-profits intersected, and I retired, which lasted about 30 days, when my wife put her finger in my face and said, "You need to go do something," which she was right, and ran into some really, really bright people in Peoria, Illinois, of all places, which is where VirtuSense is headquartered and where I'm the chief medical officer now.
Wow. So many interesting intersection points. It's fascinating you bring up the speech recognition, because I've been circling around that domain for a long time. And based on the timing that you describe, I'm not surprised to hear it didn't work. I think one of the things that we failed to do was to sell appropriately. We tended to oversell. Not that the technology wasn't capable, but the hardware wasn't, as you rightly surmised. And, I think it was 94 at the radiology conference where the demo was taking place. And the PC that was underneath the desk was the most souped up. I mean, if it was a car, it would have had dual turbochargers, extra memory. I mean, it was just, blazingly fast for that era. And of course, when you went to implement it, you didn't have that technology. And of course, it started to cause all these problems. And, that meant it took a lot longer. But I think we've reached, a different time, and it's starting to add value, and helping, I think, in the EMR, especially where there's a lot of challenges. You've obviously had a lot of experience implementing. You've seen that. But you remain a believer. And I have this conversation with a lot of physicians. Many have been so challenged, they're extraordinarily frustrated. But I think you principally see the value of technology and what it can do to help deliver better care, higher quality, and more equity across the population that needs it.
Yeah, no, I appreciate that. And, interestingly, I also seen what it can't do and what it does do to physicians and people who are trying to manage patients. So I think I've seen both sides of it in that regards. And that's, honestly, that's where I formulated my own understanding and my own sense of what I think this all represents. And it's more like a triangle where you have technology, you have data, but then you have relationships. All of them have to be in place in order for things like and that's how I define virtual care, that virtual care can make it the impact that it needs to make. So to me, the technology and the data end up being an augmentation to the caregivers, not a replacement for the caregivers, nor is it the sine qua non to the final solution, so to speak, when it comes to healthcare delivery.
Yeah, no, I think that, and that's one of my favorite words around innovation. I bristle a little bit when people talk about artificial, because that tends to imply a replacement. But I think that's exactly right. It's the augmentation that allows you to replace the mundane tasks or tasks that don't need human interaction. Those relationships are essentially the foundation, and anything that gets in the way. And I think that's what we did with technology was we put it in such a way that it became a barrier as opposed to a supporting agent. Tell us a little bit about your thoughts around how we reverse that. And in particular, as I think about this, you were part of the sort of original push for telemedicine, telehealth, which, much like speech recognition, was 2 years away for 10 years. I think we've crossed that barrier now.
Yeah, I think, and actually technologically, we crossed that barrier a few years back. However, it took a pandemic to actually generate the interest from healthcare givers and physicians who move at glacial speed at the end of the day. I mean, it's interesting to see a bunch of scientists, but I experienced this both in my work as a PhD candidate and then later running the medical group. And practicing myself, is that physicians and scientists don't move very rapidly. They think of solutions in terms of decades rather than the type of, the pandemic once again was an example of that. Look at what happened with vaccines. We created vaccines in less than a year rather than a decade, which we've seen in the past. So we've had an acceleration because the pandemic uncovered the weaknesses in our healthcare delivery model. To which now one can see some of the advantages of telemedicine, but more importantly, virtual care, because the asynchronous communication and the gathering of data through sensors becomes just as important as the actual communication through face-to-face telemedicine.
So as you think about this innovation, before we sort of dive into the expansion of this across additional devices, the augmentation with oversight, intelligence, and the supporting act, how do we start to address a system that has essentially, I don't want to say failed is the wrong word, but it's certainly not serving the widest population to deliver the best possible care within a budget that, doesn't keep expanding beyond, any reasonable boundaries?
Well, honestly, you follow the money at the end of the day. Economics has driven the healthcare system that we have today. And that's not to say, physicians and nurses are absolutely wonderful people. There's nothing more inspiring to see them at the bedside or in the exam room talking to the patients and working with all their issues. However, the healthcare system in general, from an economic standpoint, is saying the more I do, the more I make. And therefore, the value that is placed on things that you can charge a lot of money for. The perfect example that I always gave when I was talking to my primary care physicians, of which I was one of them, was that I could manage a complex diabetic and make and be able to bill $35, and my podiatry compatriots could get $35 a toe for trimming a toenail. The value it was placed on doing things and testing things and large hospitals And so you saw an economic driver that essentially gave us the absolute perfect system for the results that we're getting. So I'm a believer that you got to change the economics in order to change the entire healthcare system. Now, okay, so that's like getting the Queen Mary to change on a dime, which isn't going to happen. But if you change the economic incentives, the infrastructure to keep people healthy and well, and to be preventative rather than reactive, are all in place. We're seeing that once again with the pandemic, when all of a sudden virtual care, where you could people did not come to the doctor necessarily, they could stay at home, and now you've made your physician much more efficient and effective, and increased access, a small portion of what needs to happen in order to change the healthcare system.
So how do we I have this conversation over and over again. Do you think we're moving towards a model? Paid to do seems like a core problem, and unless we move it or change that, it will continue to. You get what you incent, and I agree with you 100%. I mean, this is not about the individuals in the system. This is the system driving behavior that is inevitable with all the externalities to that. How do we change the way that care is delivered so that that's no longer the case? I mean, it just seems like this is such a challenge to move away from this pay for activity.
Yeah, and so first one has to understand that the economic drivers are already beginning to be put in place. You've got 35 to 38% of the Medicare population, which is some 20 million people, 20 million patients that are in a Medicare Advantage plan of some sort. A Medicare Advantage plan shares in savings if you are able to keep people, the utilization down, but also keep people healthier. And what a great incentive. Let's keep people well rather than react to them being sick. You look at ACOs and the MSSPs that are out there. They also do the same thing. So the economics are there. In fact, if you look at a healthcare system, and we did this when I was at the virtual care center, we put a home model in place to decrease the cost of that 5% that spend 50% of the dollars. We decreased that cost by 60%. So you're talking about a 30% decrease in the entire population that you're managing, that those patients are derived from, right? So if you take a health system that has $1 billion in revenue, just take a generalization. They have about 20 million Medicare Advantage patients. If you put a virtual system in place that just manages that 5%, you generate 27 million in new net. High level numbers, but that's a pretty big incentive. Now all of a sudden, people are saying, well, how can we help people not fall in the hospital? Because there are technological ways to do that, which is what my company does today. How do we keep people at home instead of in the hospital? Well, maybe we can monitor them at home with wearables or biometrics or other types of technology and have those video visits. There's all kinds of technology that, it's as though when I tried to do the dragon speak, which then became nuance later on, as you're well aware of, it wasn't ready. It's ready. We are ready right now. And I think the economics are there. I think, Nick, and you probably know better than I do because you talk to people across the country as well as across the world. The people who are in place today in health systems who have the power are not incented today in order to make radical changes because of economic uncertainties to a new economic model. It'll be those. Look at the only hospital system that probably didn't lose money during the pandemic was Kaiser, because Kaiser's already in that model, right? And I think that's a fact. So, once again, I hate to keep harping back on the pandemic, but it was a catastrophic change to this country from a healthcare standpoint that is beginning to unravel the inadequacies of our healthcare delivery model. And it is a delivery model. It is not, the diagnostics are wonderful. The physicians are good. The nurses are good, but it is a delivery model that needs to change.
So for those of you just joining, I'm Dr. Nick, the Incrementalist, and today I'm talking to Dr. Tom Hale. He is the Chief Medical Officer at VirtuSense. We were just talking about the pivoting or the move of the healthcare system away from this fee-for-service to a much more holistic, total coverage with shared risk along the lines of Medicare Advantage plans, ACOs, MSSPs. And, you know, the silver lining, I think you and I probably share this view, and, you know, nobody would wish the pandemic ever, but given that we had it, I try and seek those silver linings, and I agree with you 100%. We have exposed the soft underbelly of inadequacy of our system in so many areas, and it is our opportunity now to really drive change. And some of that change we started to see, I think, you know, it's going to stick with telehealth, telemedicine that's being delivered, but there's more to it. And I think this is where some of the technology that you've started to work on and, you know, your organization, which is pushing out insights into the home. I know you've started with just surveillance. Tell us a little bit about what VirtuSense is doing and how you're going about that.
No, I appreciate that, Nick. So VirtuSense is a company that is actually deals in significant artificial intelligence and taking data from sensors and then turn that data into knowledge by utilizing algorithms of artificial intelligence. And I, like you, bristle a little bit at the thought of artificial intelligence because it does sound like not only an oxymoron, but it's probably not true. It's just that pure gut ability to be able to power through mounds of data and then turn it into some knowledge that someone who actually has intelligence can then do something with. So we use LiDAR sensors to put surveillance on patients in acute hospital beds, and because of the information that we get from those LiDAR sensors, we can tell when a patient has decided to exit the bed or a chair. That leads to a fall, by the way, in most cases. And in fact, $52 billion of Medicare is spent on falls. Every 20 minutes, a Medicare patient dies of a fall. And a fall happens almost every 9 minutes. So it's not a small issue. And so what we're able to do with the artificial intelligence by getting the sensing is that we can then alert our caregivers. The nurses are sometimes there's fall specialists on the floor much earlier in the process of exiting the bed so that they can get their 30 to 60 seconds, they get the alert 30 to 60 seconds ahead of that patient exiting the bed. And so they greet the patient rather than find the patient on the floor, which is what happens today without that kind of technology. And sensitive to the fact, because I think I lived it when I was at the bedside, is that we only have a half of a false alert every 24 hours. So it's not like they get a bunch of alerts, of which we pick and choose some of those that can help the patient. It's very sensitive, and it's also very specific.
So that's fascinating. And I think, you know, big progress on many of the methodologies that we have. And, you know, we've struggled with this for a long time. It's not a new problem. It's something that's been going on. But, you know, those are staggering numbers that, you know, if you could just bring to bear just a little bit of innovation that prevents. And it sounds like, you know, there's a real opportunity to actually play some intervention. I like the thought, you know, meet the patient before they get out of bed as opposed to finding them on the floor. I think that's, you know, a great visual. But what else can you do? I mean, it sounds like, you know, the acquisition of this data starts to bring more value. What else is going on, and where do you see this going?
So it becomes natural at that point in time, because even though our first product was a fall prevention, what we really are is artificial intelligence taking in sensor information. So why not use biometrics on patients to partake in that information as well? We learned something when I was at Virtual Care Center, was that if we are able to obtain the heart rate and the pulse and the temperature on a patient while they're in the acute setting, that we can actually intervene into sepsis much earlier. And we had results where we decreased the progression of severe sepsis to septic shock by 95%. Not because we used new treatments, not because the treatments were good. They just weren't getting to the patient in time. So just think if in COVID as an example, if we can take a patch that can check patients' O2 saturation, their blood pressure, their pulse, their core body temperature, a single lead EKG, and do that every 5 minutes, or even every 15 minutes, you've all of a sudden got 15 minutes, you get 96 new data points where in the past you only had 4. So now we can take that, and we've done this actually, and we're moving now to an armband, so a person can actually go home with it. So think of during COVID, if you had this patient with the armband, you could send them home earlier, where everybody does better if they're being monitored and if they have access to patients. Finally, Nick, I'd be remiss to say that the other things that we put in our module that's on the wall is the HD video and HD audio. So it actually virtualizes the room almost immediately. So the nurses actually can get the alert and camera into the patient's room and see the patient should they so choose. And so can physicians, and so on and so forth.
So I think it's interesting you talk about, adding in additional and pushing the patient back into the home. I mean, if you think about that in the pandemic crisis, again, another opportunity and more acceptance. I think, pre-COVID, the idea that we would say to a patient, no, we're not going to admit you, we'd rather keep you and monitor you at home, was a far less palatable position than I think it is now. And it's certainly, the preferred modality, unless there's a good reason to admit people. And here we have sort of technology that says, hey, we can do this and do it. So you're going to see, I imagine, this going into what I would call the medical home.
Oh, definitely. I definitely say that to be the case. The 5% that we were monitoring with very crude technology in the virtual care center some 10 years ago, now is much more sophisticated. So we can be monitoring these patients at home, preventing. If someone has cancer, monitoring doesn't cure the disease. What it does do is keep stupid stuff from happening.
Right.
The stupid stuff of, oh my gosh, I've getting some chest pain. So instead they call and they just fallen down and hit their chest, right? But they call their neighbor who's their favorite consultant, who then says you need to go to the emergency room. And the next thing you've got someone in the hospital and a $30,000 bill later to be told you have chest wall pain. The same thing if they're being monitored and they fall and hit their chest and then get they get a telemedicine visit, and all that information is there for the nurse or the physician to be able to monitor. You stop the stupid stuff from happening. I mean, honestly, stupid stuff accounts for about $1 trillion in cost, right?
I don't think I've ever seen that as a line item, just to be clear, but but I'm sure you're right.
Well, I always say that there's Hales economics. Hales economics is a triangle. There's three levels. One is you invest money into preventative care. Tell people to stop smoking, stop drinking, exercise, difficult long-term payout. And then you got the middle part of the triangle, which is the acute care. You react to that. That's what the whole healthcare system is today. And then the third part of the triangle is the stupid stuff. And stupid stuff is, honest to God, all about increasing access and decreasing variation in care delivery. And that can't be done unless you put the infrastructure in place in order to increase the access, which can be done virtually with both face-to-face telemedicine and also asynchronous care, like texts and emails and so on and so forth. And then decrease variation in care, you use those that you can't do that without having data, analyzing the data and being able to give solid information. If you think about it, a patient today sees even the sickest patient sees the caregivers maybe 10% of the year, 36 days, maybe 50 days. That leaves 85% of the rest of the year as a dark hole, of which we know nothing about that patient or what's going on. And we rely on the patient to be our sensor, be our alert system. And the patient raises their hand and says, I don't feel well, and off we go.
Well, I think a perfect note to end on, Hales economics. I like that. So unfortunately, as usual, we've run out of time. So it just remains for me to thank you for joining me on the show. It's been a great pleasure. I think some great insights and, tremendous opportunity. Thanks for joining me.
No, I appreciate that, Nick. As one can see, as I got worked up, it's a passion for me, but it's something that really can work.
Thanks for joining me today. Do you have any better ideas, or have you found a small incremental change that's brought about a big improvement in your world? Let's continue the conversation on our hashtag, The Incrementalist, or share with me at DrNick1 on Twitter. You can find more information about the show on our program page at healthcarenowradio.com. And tune in next time to hear my discussions with leaders and innovators from around the globe who've revolutionized their space by using small incremental improvements to achieve their moonshot. I'm Dr. Nick, the Incrementalist, and I'm starting a revolution through evolution.